It's my pleasure to introduce to you now Professor Seraj Wali. Professor Wali is a professor of internal medicine, pulmonology, and sleep medicine. Professor Wali will speak about hypertension and obstructive sleep apnea. Yes, the floor is yours.
Okay, thank you very much for this nice introduction. First of all, I would like to thank the organizing committee, Dr. Tawfiq Al-Bassam, for inviting me for this prestigious conference. الصوت كويس؟ Bismillah. So this is the outline of my talk, which is the relationship between sleep apnea and systemic hypertension. We'll start with the introduction. As you all know, sleep apnea is characterized by intermittent cessation of breathing during sleep due to the collapse of the pharyngeal muscles. Okay, sleep apnea is common. It has been reported in Western countries as well as in Asian countries to be 2% in females and 4% in males. In Saudi Arabia, a population-based study was conducted at King Abdulaziz University, and it recruited about 2,600 individuals, and it showed almost the same percentage, 2% in females and 4% in males. If we take this a little bit further and we use the definition of sleep apnea recommended by the American Academy of Sleep Medicine, which is more clinically oriented, it's 5% in females and 12% in males. Believe it or not, it's more common than bronchial asthma and more common than COPD, but unfortunately it's underestimated. So what happened to our blood pressure during sleep? It's already been mentioned by Dr. Abdul Hamid, but our blood pressure during sleep, it goes down a bit, about 10% from wakefulness, and that's called nocturnal dipping. And this nocturnal dipping is very important since its absence is associated with increased risk factor for cardiovascular diseases. So let's go to the mechanism of systemic hypertension in sleep apnea if it happened. Initially, let's go through just the principle of the pathophysiological effects of sleep apnea in simple terms. When a sleep apnea patient falls asleep, the muscles of the pharynx tone decreases, and this would cause collapse of the pharynx. This would lead into apnea, apnea associated with drop in oxygen saturation, increase in the respiratory effort in an effort to overcome the obstruction, causing swinging in the pleural pressure. This would eventually lead into arousal, which is a brief awakening, unappreciated by the patient. This arousal is associated with sympathetic surge. This would lead into opening up of the pharyngeal muscles again, reventilation, and oxygenation again resumed, and CO2 that accumulated would be washed out. Patient would sleep again, and the cycle is repeated about hundreds times in a single night of a sleep apnea patient. So with this cyclic hypoxia, reoxygenation, the repeated arousals would all lead into increase in the sympathetic nervous system activity, which is eventually would lead into hypertension. This is what we believe in. This is just a brief record of a patient with sleep apnea. You can see the repetitive drop in oxygen saturation, which is synchronized with an increase in blood pressure, systolic and diastolic. So, what evidence do we have in the literature that sleep apnea patient would have increased sympathetic activity? Well, it has been shown in the literature that the sleep apnea patients' epinephrine level in urine in 24 hours urine collection is increased by almost 50 times higher than that of the controls. And treating this patient with CPAP would decrease the epinephrine level, thank you very much, by almost 25 by almost 25%. And also the muscle sympathetic nervous activity in the blood vessels is also increased, and treating these patients with the CPAP would decrease remarkably the sympathetic nervous activity in the muscles of the smooth muscles, in the smooth muscles of the blood vessels, compared to the patients with sleep apnea who are not treated with CPAP. So this sustained sympathetic activity, as we mentioned before, would lead eventually into systemic hypertension. And so no wonder that more than 50% of our patients with sleep apnea do have hypertension, and about 40% of your patients with hypertension do have sleep apnea. So let's go through the literature review regarding the relationship between sleep apnea and hypertension. There are numerous studies available that show that sleep hypertension is common among sleep apnea patients. This is just one of them. More than 2,600 individuals referred to the sleep lab for rule out sleep apnea. The outcome was morning and evening blood pressure in addition to sleep study, and the finding that the sleep apnea was associated with increased prevalence of hypertension, but not only that, but hypertension prevalence increased smoothly and linearly with the severity of sleep apnea, concluding that there is a strong relationship between sleep apnea and hypertension. If you look at the incidence of sleep apnea, would sleep apnea lead into hypertension or not? There are 3 studies that looked at this issue, 3 longitudinal cohort studies. This is the first one, the Wisconsin sleep cohort, recruited 700 individuals. None had hypertension as baseline. All underwent sleep study at baseline and followed for 4 years for vital signs. The interesting finding was that the odds ratio of incident hypertension was significantly higher in sleep apnea patients. But again, not only that, but the more severe the sleep apnea is at the beginning of the study, the more likely is to develop hypertension. Now, these patients with severe sleep apnea had 3-fold the risk of developing hypertension compared to the control, and those with mild had about 2-fold the risk of developing hypertension compared to the control. So, concluding that the risk factor for hypertension, that sleep apnea is a risk factor for hypertension even after correction to confounders. However, this was followed by 2 other longitudinal cohorts that conflict with this data. This is the sleep heart health study. They recruited about 2,400 individuals. Again, they did not have sleep apnea, hypertension at baseline, or underwent sleep study at baseline and followed for over 5 years. And the finding was that the odds ratio of developing hypertension was significant initially in relation to the severity of sleep apnea, but when corrected to confounders, this relationship was attenuated significantly to a statistically significant level. Another study, the Vitoria sleep cohort, recruited again about 1,200 individuals. None had hypertension. All underwent sleep study, followed for over 7.5 years, and the finding was almost the same. Initially, they thought there is a relationship with sleep apnea, but when corrected to confounders, this relationship was lost, concluding that sleep apnea is probably not a risk factor for hypertension. So how can we make up the one conclusion from all these conflicting data? Well, we have to keep in mind that there are significant methodological differences between these 3 longitudinal studies. As an example, in the sleep heart health study, individuals were about 10 years or more higher than the individuals in the Wisconsin sleep cohort. And these patients, this age group, may be resistant to the or less sensitive to the hypertensive effects of untreated sleep apnea. There are other methodological differences, like the blood pressure. How was it measured? By ambulatory, 24 hours ambulatory blood pressure in the Wisconsin, which was positive, but was measured by the sphygmomanometer in the other two conflicting studies. The sleep apnea, how was it diagnosed? Again, this was different from in the three longitudinal cohorts. Having said that, Jose Murray took this a step further. He and his colleagues looked at the effect of CPAP, which is the gold standard treatment of sleep apnea, in preventing development of sleep apnea, of hypertension. So they recruited about 1,800 individuals. Again, they did not have hypertension at the beginning. All underwent sleep study, followed for more than 1,200, followed for a median of 12 and a half years. And the finding was interesting. Those with sleep apnea treated with CPAP, initially there was significant increased risk of incident hypertension compared to the controls who did not have sleep apnea. But when corrected to confounders, this was lost. This relationship was lost. However, sleep apnea patients who were not treated with CPAP for any reason or another, the risk of developing new hypertension was higher compared to the control, and that remained true even after correction to confounders. Concluding that sleep apnea is associated with increased risk of incident hypertension, and treating it would prevent development of new onset hypertension. Another piece of information in the literature that strengthened the association between sleep apnea and hypertension is the high prevalence of hypertension among severe patients, among refractory hypertensive patients, the high prevalence of sleep apnea among refractory hypertensive patients. It reached up to 95% in one study. And that actually confirmed this extraordinary high prevalence of sleep apnea in these patients supports the important role of sleep apnea in the pathogenesis of drug-resistant hypertension. The last part of my talk is the treatment effects. Again, there are numerous studies showing that the treating sleep apnea, which is mainly by CPAP, is effective in reducing the blood pressure in hypertensive patients. This is just one of them. 118 men with sleep apnea randomly assigned to receive either CPAP or no CPAP or subtherapeutic CPAP, followed after a month for the blood pressure, and it was found that the CPAP patients in black dots, after treatment with CPAP, the mean blood pressure decreased significantly, while those in white dots, the blood pressure remained unchanged, suggesting that CPAP is effective in reducing the blood pressure. Again, there are several meta-analyses that looked at this issue. I will just report the latest one, published in CHEST 4 years ago. 25 randomized trials was reviewed, and it was in favor of CPAP as effective in reducing systolic blood pressure in patients with sleep apnea. And again, the same thing was true for the diastolic blood pressure. How about blood pressure in resistant hypertension? Well, this is again was looked at. This is an open-label randomized controlled trial. And it showed that 194 patients were with resistant hypertension randomized to receive either CPAP or no CPAP, and the net effect was actually in favor of the CPAP. CPAP has been shown to reduce mean systolic and diastolic blood pressure compared to the control. However, you have to keep in mind that the effect of CPAP in reducing the blood pressure is modest, about 2 millimeters of mercury, but that has been shown to be effective in reducing cardiovascular risk factors, or cardiovascular risk rather.
5 minutes, Dr. Seraj.
Sure. This is one of these studies that shows that valsartan is 4 times more effective than the CPAP. Having said that, not all studies in the literature support the effectiveness of CPAP in reducing the blood pressure of sleep apnea patients. There are few studies showed that it has no effect. This is just one of them. 68 patients with sleep apnea randomized to receive either CPAP or subtherapeutic CPAP, and the blood pressure was followed after a month, and actually there is no change. Again, another study using refractory hypertensive patients treated with CPAP versus no CPAP. Again, there were no significant change in blood pressure when CPAP was used. So how can we make up these differences in the reports? Well, again, difference in methodology is great. The sample size is different, the study population are different, the outcome measures are different. The baseline hypertensive status is different. It has been shown that the longer the hypertension is being on board, if you like, or the longer the history of hypertension, the less likely for the patient to be responsive to the antihypertensive effect of CPAP. Well, other factors will include whether the patients are on antihypertensive medication. That will make the CPAP less effective. Whether the patient is symptomatic, have daytime sleepiness, that will make them more effective for the CPAP. The more severe the sleep apnea, the more likely it is to respond to CPAP. And the duration of follow-up, initially a month may not be long enough to respond to CPAP as antihypertensive measure. You may need longer follow-up. So in summary, I think we have strong evidence to say that there is a strong association between sleep apnea and hypertension. And this association, I think we have enough evidence to promote this association to a causality relationship because of the high prevalence of the hypertension among sleep apnea patients. The sleep apnea patients are more likely to develop hypertension upon follow-up than others, than the control. And it is those response effect. The more severe the sleep apnea, the more likely for these people to develop hypertension. And the effect of treatment. I just mentioned CPAP treatment in my talk, but actually even the mandibular devices has been shown to be effective. And so all these together support the fact that sleep apnea is most likely an independent etiology of hypertension. Keep in mind that this reduction in blood pressure by CPAP treatment is modest, and we may lose it in some special individuals like those with longer standing hypertension. Thank you.